Great. It is March 11th, Tuesday, House Healthcare. And we're joined today by Devin Green and Jonathan Reynolds. And they're here to speak on section 3 of H202. And then we'll have Ledge Council in to continue the work that we did last Friday or the Friday before last. So thanks for joining us.
Great. Thank you for having me. Devin Green, Vermont Association of Hospitals and Health Systems. And I have Jonathan Reynolds remotely from Rutland Regional Medical Center. He can get into the details. And so he's sort of pinch hitting if there's a question. And I have a handout that is on the website. I can throw it up on the screen. But the long and short of it is, we do support reporting requirements in H266. We really appreciate the committee's effort on this. The current section 3 of H202, which is slated to go into H266, is a combination of Minnesota and Maine legislation. In talking with Jonathan and others, we looked at the Maine legislation, and we do think that provides very helpful information that also does not increase administrative burden for hospitals. So we have a listing of the Maine legislation on the handout for you to follow along, but basically a description of how the hospital uses the savings from participating in 340B, and we are supportive of that no matter what kind of language you do. The annual estimated savings from 340B program to the hospital, comparing the acquisition price to group purchasing organization pricing. And so this will give you a sense of the scope of the program, a comparison of the hospital's estimated savings under the 340B program, including examples of the hospital's top drugs purchased through the 340B program, and a description of the hospital's internal review and oversight of the 340B program. So that's the Maine legislation that we support, state of Maine legislation that we support. And then we do have responses going through section 3 that we can go into as well, if that's helpful.
That would be.
So for section 1 in that part 3, the aggregated acquisition cost for all prescription drugs at the hospital obtained through 340B during the previous calendar year. I think Minnesota saw this too. It's a little bit difficult to get this data. It would be a bit administratively burdensome for hospitals. So we are suggesting that this could be collected through the prescription drug wholesalers, if that's something this committee is interested in doing. Number 2, the aggregated payment amount that the hospital received for all prescription drugs during the previous calendar year. This can be done with the contract pharmacies, but the hospital drugs are separately billable and are part of a bundled payment, so it is usually more difficult to tease that out. So again, this is where the Maine legislation would be helpful. The aggregated payment amount that the hospital made to pharmacies, we can provide that information. The aggregated payment amount that the hospital made to any other outside vendor, we can provide that information. Number 5, all other expenses related to administering the 340B program, including staffing, operational, and administrative expenses during the previous calendar year. This, once you get into staffing, a lot of times with a lot of our hospitals, it's difficult to tease out, someone might be doing 340B and doing another thing. And so it's just administratively burdensome to report on that. So we'd want to, given that we're providing the amount and the cost for doing the program, we think that's reasonable. The staffing doesn't seem reasonable in this case. And then number 6, the names of vendors. We're just curious what the purpose is here. And I do wonder if it may create a little bit of a chilling effect when bidding on contracts. I'm just not sure what naming the vendors does in terms of looking at the program holistically. Number 7, the number of claims for all prescription drugs. We are fine with reporting the number of total claims by payer type. This is where we get a little cautious. One of the ways that pharma has sort of undermined the program is by trying to reverse engineer data by like requiring data collection and reverse engineering it. So we would propose reporting in the aggregate for across payer types, all the claims, as opposed to breaking it down by each one. Number 8, how we use our savings from the 340B by that information. Number 9, the information, we're happy to provide that information. And then such additional information as the board may request. So this one, again, as we stated before, what we've seen is data collection as a way of undermining the program. We would want predictability in this space and to ensure that it doesn't get into any sort of undermining. And so we would leave it to these parameters as opposed to leaving it totally open. So we would request that that be eliminated.
We have one question. Bobby?
Can you go into more detail about that? I just want to understand how the undermining works and how they use that against you.
Yeah, so, and I might ask Jonathan to go into detail about that if you'd like to, Jonathan, but my understanding is it's just, it's sort of a way to, well, Jonathan, I'll hand it over to you for that one. I don't want to.
Yeah, correct. Thanks, Devin. So I think to answer the question, as 340B data becomes more available, especially at the, as we approach the claims level or the payer data level, that is where the analysis can be matched up with dispensations. And this data is very powerful, especially as it relates to the drug manufacturers and their quest to move towards alternative 340B models, especially with a rebate discussion that's out on the table currently at the federal level that they're pushing. So the more that we can keep this level of data not only reasonable and keep it transparent to meet stakeholders' needs, but also protect our information from the drug wholesaler level, I guess solidifies the stance that both hospitals and FQHCs can continue to operate the program as designed.
I guess I'm still not clear on how they're using the data to undermine. Are they using it to steer towards higher price medications? Are they, how are they undermining?
The drug manufacturers are, regarding 340B, they're extremely focused on certain areas of what they would consider to be obscure uses of the program. And we feel that those, we are doing everything with due diligence. We have regular audits performed. The more information that we can provide to them will enable them to instill additional programmatic requirements that we've already been subject to, such as something referred to as ESP, where it requires us to submit data. So it's really a complex program. I'm sorry, I'm not clearly answering your question, but it really distills down to the fact that the more information we provide with pharma, the more unique ways that they can craft solutions to come back and try to shut down the program and decrease access by covered entities. So there's a level of discomfort that we have with sharing information with them because of that.
What if there was an enforceable prohibition against drug manufacturers from using data that you provided to the state in that fashion?
I think the question would be, that would be helpful for sure. Absolutely. It's a matter of, what will they abide by that or not, especially given their national intent of attack on the program.
Thank you.
Go ahead, Devin.
And that's all I have. That's all I have. I know that in the past, manufacturers have used data to restrict access to certain pharmaceuticals too. So I think that's just the concern that we have there.
Any other questions from the committee? Go ahead, Blaine.
Yes, I'm curious, how often do you provide information or are you audited by the Department of Health and Human Services?
I will look for Jonathan for that one.
Yeah, happy to provide an answer to that. So I can't necessarily speak to the HRSA audits. We have been inspected twice by them, by those audits. However, it is a programmatic requirement that as part of that audit that we show we are doing our own internal due diligence. So as a result of that, here at Rutland Regional, we have a yearly independent audit by an outside organization that performs a full assessment of our programmatic integrity, both for the contract pharmacy component and for services and medications provided within the four walls of our hospitals and our clinics.
Okay, so you do a yearly audit,
Mhm.
and the information that you provide, is it the same information that we're asking in this bill? Or is it similar
No.
or is it different?
That's a great question. The information that we provide during those audits is highly specific and is at a specific drug level, patient encounter level. So we're tying back those medications to ensure compliance with the program. This information that we're discussing here today is a higher level, non-patient, non-aggregated level of information. So it's two comparisons. I'll just finish by saying that the audits that we commission within our organization just are highly specific and much more stringent than the information that we're talking about here.
Okay, and then I guess I would ask the committee, what's our objective? What are we trying to do with this bill in collecting information?
Thanks for asking me that.
Well, I'm not asking you necessarily, Representative, I'm just, as a whole, I just would like to know where we're going and what we want to do with this information once we
I'm
get it.
respond as the sponsor of the bill.
Yeah, go ahead.
I'm at the sponsor. Actually.
You're the sponsor of this section,
Both of
yeah.
them. The 202 part that we're talking about now, so the goal is to still protect the 340B program in the sense that it supports hospitals. But we also want to have more transparency about how the federal money that or the money through the federal 340B program, we want more transparency about how it's being used.
And what happens to it after?
And I think I asked our chair earlier about if we were going to talk about H202, because our agenda only has 266 on it. And she said that Jen would be talking to us
I
sometime
know,
today
we're trying to get a hold of Jen now.
about this, so Jen can go into more detail about both bills.
But apparently, I may be wrong, but the Green Mountain Care Board has asked for some of this information in the past. So I guess I'm wondering, why do we have to put this in legislation when it appears that hospitals are adhering to requests when they're requested from the Green Mountain Care.
I mean, I will just say that this is more detailed and the main legislation is also more detailed. And standardized than what the Green Mountain Care Board has asked for in the past.
Lori?
My question was Maine.
Mhm.
When did they start collecting that data? Do you know?
I think that was very recently. I can't
Okay.
remember if it was passed last year or the year before, but I'll check.
And with that legislation, is it just reporting or are they doing, do you know if they're doing the same thing that we're trying to do? Like in general with 340B?
I just looked at the reporting piece, but I
Okay.
can go back and look at that.
Okay, thanks.
Can we,
So Charles Becker for the record. So Maine does have, similar to what we passed here in Vermont last year, a prescription drug affordability board. They have a prescription drug affordability board, and the data they're collecting from this 340B transparency legislation is to inform the work of that
Okay,
transparency of the affordability board.
thank you.
Representative Gina?
Yeah, I raised my hand earlier when Woody asked his question. Because I think that like Mari explained pretty well, like the goal of the goal, but I wanted to explain like the intent for me for the goal. That I think that creating, by adding in this, like this more detailed guidelines, it's like, why, I guess what I'm answering is like, why do we want more transparency? To me, increasing when humans like increase our awareness or mindfulness of our behavior, then we naturally change our behavior. Like, this is me speaking as a psychotherapist. So if you think about it organizationally or structurally, by creating these guidelines, for everyone to be aware of, it's going to standardize our behavior and it's going to increase our collective awareness of our behavior. And that alone may change the behavior of some of the players. Like when the cost is more open to everyone to see, some people might act differently because everyone's watching. So I guess I'm explaining why I think we need the more transparency. The goal to me would be to increase our collective consciousness of how we're spending money in the healthcare system so that we can spend it in better ways. I tried to say that simply, but
Can I say it even more simply?
I don't know, can you?
It sounds like you're saying to create standards.
Yeah, but I guess I was saying why I want to create standards.
Okay.
It's like, why do we need standards? Why do we need transparency? To me, it's not about getting people in trouble. It's about kind of setting common goals for us all to work towards. Then we're all on the same page. We can all look at what each other's doing and just that consciousness shift alone will change human behavior. But then once we're all aware, we can also talk to each other about it more and say like, hey, why are you doing this? Why is this like this? So that's why I think it's important to do these things.
Okay, now.
Yeah.
I know there's going to be some reaction to that. Mari, you're the sponsor of the bill.
just a real quick addition to that is that we want to know that real people are being helped by 340B. Or if they're not being helped, we want to know that too.
Lori?
No, I'll let, he's had his hand up.
I'm sorry. I didn't see
Well,
that.
I guess I'm looking at it this way, Green Mountain Care Board, they can request information, right?
Mhm.
Okay, and they could be a fee to that. I think I read that they could charge for information that they receive. Okay, so maybe not, okay, but I'm just saying, I thought I read that. Now, number two, we're gonna also put burdens on everybody else here at a cost. Right? Administration costs. These hospitals, are they gonna they can handle that without hiring new staff?
Well, I do think there is a cost for pulling data, and their balance is always, does the data outweigh the costs, the administrative costs? We feel like the main, so I reached out to my colleagues in Maine. They said that this was workable for their hospitals. I reached out to Minnesota. I didn't hear back from Minnesota, so that's why I'm supporting the Maine legislation.
Okay, so you're, one more quick one to not follow. You are supporting the main legislation. Down below with all your questions, are you supporting all that too?
I am saying, we want the Maine legislation.
Okay.
If you're not, but I have to cover all my bases
Okay.
and say,
Okay.
if you're not gonna go with the Maine legislation, here's our reaction to all the Section 3 ones.
Thank you.
Thank you. Lori?
This is more general comment than it's a question for Devin. I just want us to be, I agree with everything and transparency is good and we want to make sure this is helping Vermonters. And at the same time, we receive a lot of data and ask for a lot of data in this committee that we never look at or we don't use. So I want to make sure we're clear on whatever we put in, how it's going to be used, what questions will it answer, and how we'll make sure that we know we're helping Vermonters, right? So I would love when we get to the point about talking about what specifically we're going to get in is like really look at what is the data going to give us and are we going to be able to do anything with that data, make any actions? And if not, why are we asking the hospitals to collect it?
Okay. Any further questions?
Well, I was just
Where
thinking-
do you come down on this now?
Well, I was just thinking if we're just wanting to look at the data and see whether we're helping Vermonters. Is it possible to do a test, you know, for maybe a year or two and see how it goes before we implement any legislation,
What is sunset?
something like that. I mean, if we start collecting all this data from now till the end of time, and we look at it 1 or 2 years and we figure, well, it's being used correctly or what have you. Does it need to be continued forever?
So Woody, what you're proposing or recommending?
Well, I'm just thinking and talking out
Yeah,
loud.
I'm just taking a note. I want to make sure I got it right. That maybe we should look at this for a couple of years and see if,
Perhaps, you know, it's just a thought.
Brian?
Yeah, in the spirit of trying to make it as easy as possible and like improving efficiency, I'm curious how the data gets collected. Is there ways that technology like AI can help? Because these companies collect all of our personal data very easily and sell it. Like there's got to be a way that, you know, that it could be collected and shared transparently easier. You know, I'm curious how it's collected is, you know, you don't have to get into the details, but like how much work is involved in collecting it? How many staff? If you don't know, it's okay too. But like, you know, just like trying to get us the scale of the work involved.
Yeah, I don't know off the top of my head. It might be something that Jonathan can speak to a bit. I think we're just trying to make sure that the data is not administratively burdensome to collect, actionable, and useful.
And
Go ahead, Woody.
then I'm also thinking, are we capable here at looking and understanding the data, or are we going to have to hire an outside source to review that data and tell us exactly what we may be looking at? Just really thoughts.
Thank you, Woody. Any other questions? Jonathan, do you have anything to add?
Yeah, I do, if I may add something very briefly. So thank you for the opportunity. Jonathan Reynolds, Vice President Clinical Ops at Rutland Regional. So I understand and I agree that transparency with the 340B program is important, and it's important for all stakeholders involved, really to just aimed at the success of the program. There is one specific piece that just to touch on here is that as currently stated, I think part 2 of that section 3 of 202 speaks to requiring aggregated payment amounts for us to report. Specifically with that, that is it's an easy number to report for the contract pharmacy side of 340B. Those are the prescriptions that you just pick up at an outpatient retail pharmacy. But it's nearly impossible for us as at Rutland Regional to provide that information for 340B drugs that are used in a hospital, clinic, emergency department, outpatient setting. And that's really because our payments from our insurers are aggregated for a patient's entire encounter. So we don't, of course, we bill out services itemized, but when we receive payment from the insurers, those, so if you come in for a service and you receive lab, imaging, physician provider service, and you receive 340B drugs, those are bundled payments that we receive essentially payment altogether. And there's no delineation about how much we receive that's for, say, a CT scan versus a 340B drug that we gave. So if we were to begin disaggregating that revenue, it would really be an artificial exercise. I can't necessarily speak to how Minnesota does that. All I know is that in our revenue cycle, as it's built here within our hospital, we're not able to come to that number. And that's not an intentional lack of transparency. That's just how our financial system, how our rev cycle system is built. And if it truly was requested that we get to that aggregated payment amount, we would have to rework our rev cycle system, our EMR, at least in the temporary, add additional staff to meet these reporting burdens. And that is just where I understand that this aggregated payment amount is really a linchpin of this reporting piece. However, it's just something that we can't get there. And that's where in lieu of in that data, I'm supportive of what Devin was suggesting, that perhaps the moving to Maine's data reporting requirement is a reasonable compromise, simply because of our inability to report on that one piece of vital information toward the transparency needs. So I didn't want to go any further into that. I can go further. I don't want to belabor the point, but I just want us to translate our inability to provide that specific piece of information for what's roughly half of our 340B program.
Thank you. Mari?
So this is actually a question, not for you, Devin or Jonathan. And it's related to your concerns, Woody, about who does what with the information that we get. I wonder if we could have permission for me to ask the Office of the Health Advocate a specific question that I know they have knowledge about the Minnesota report.
Go ahead, if it'll help us.
So,
I have one more question.
Okay.
Okay, go.
Another member, Woody, asked about maybe sunsetting this and doing data collection for a couple years. Can you speak to that and whether it would still yield any results that would inform us of what you've heard we're looking for?
Yeah, I think a sunset would be appropriate because it would give you the opportunity to actually collect the data, figure out if it's useful, and then if you want to see it collected for a long period of time, you have the opportunity to come back and do that, as opposed to it being collected in perpetuity and maybe no one using it. So I'm supportive of a sunset.
Sunset. So how long? Because how long did they get the system, to get the system together to collect the data, to analyze and make it useful before we talk about sunset?
Yeah, I would say 2 years would be good.
I was kind of thinking 3 or 4, so maybe we can.
Let's go 3.
I just don't know how this process. So I'd be interested in that and hearing from different players about when that data might be aggregated usefully in a form that we can analyze and then apply.
Mhm.
What's the reasonable amount of time before we landed on something?
Okay, Lonnie? That's okay.
Thank you, Devin.
Thank you.
Charles Becker, Staff Attorney Office of the Healthcare Advocate. I hope I don't disappoint, Mari.
Oh, thank you.
Okay, all
Letting
right.
me put you on the spot.
Okay.
So we've been hearing about the Minnesota model, and in your testimony, you mentioned that Minnesota issued their first report about 340B. And I'm wondering if you are aware of who in Minnesota, what agency or entity issued the report. And in 202, I don't remember that we explicitly required a report of the Green Mountain Care Board. That's two-pronged question.
So, I mean, I think in Minnesota it was the equivalent of their Department of Health. I think that agency plays a slightly different role in Minnesota than it does here in Vermont. It's why I think we landed on having the data be submitted to the Green Mountain Care Board, since they are the healthcare regulatory body here in Vermont that is very experienced in collecting data and working with data. No, we do not specifically. The legislation 202 did not call for the Green Mountain Care Board to produce a report. I think we heard testimony from the Care Board witness last week that, because they are experienced in working with data, they could do an analysis of the data and provide some sort of report, but that would be work for them, administrative work for them that perhaps they don't have the staffing for. They haven't done an analysis of that. I mean, I think the idea behind giving the Green Mountain Care Board data, and I think they spoke to this a little bit, right, is that they're just standing up this prescription drug affordability board, and they're learning the ins and outs of prescription drug financing and where the money flows go, and giving them the data, more of the Minnesota level data than the Maine level data, could give them insights that they could work with, and standing up their prescription drug affordability board to actually do good work here for the people of Vermont.
I'm also concerned about the hospital's concerns about the use of more detailed data being used to undermine. And is that something that you're familiar that?
It is not. It is not. I mean, I know in health insurance rate review too, for example, there are concerns about reverse engineering data. I'm not a data guy. That's Eric Schulteis on my team is the data guy, right? Perhaps there are ways that you could reverse engineer costs, but I really don't.
And last question from me, given that the Vermont version of the PDAB is just getting underway, what are your thoughts about how long a sunset should be?
Great question, because I've been sitting over thinking about that. They have until I believe January of next year to submit their plan for standing up a prescription drug affordability board. So they are really just getting underway. I'm hearing 2 years, 3 years. I want to say 5 years would be enough time to, get the data, get it in a standardized format. Because I think if you read the Minnesota report, they're saying, well, we requested it in this form, but not every entity was able to comply. And it's going to take a couple of years for us to really get them to start reporting in a consistent manner. So I'd give it, more than 2 or 3 years. I'd give it, 5 years. But I do hear the point that why are we going to collect this data forever if potentially, it turns out it's not useful? If after 5 years it turns out it is useful, they could come back and request that the sunset be repealed.
And we do have other legislation potentially providing Green Mountain Care Board with more resources that potentially could be
Lots of discussion about that.
applied to, especially since it's a lot of it is prescription drug work that we want the
Mhm.
new PDAP to do. So it's, in my view, it's likely that a report would come out of this, but that it's not necessary to bind the Green Mountain Care Board to a report right now. Thank you.
Thank you.
Okay, thank you very much.
Welcome.
Now, after all that discussion, we're gonna have a legislative council come up to the other side of the table. And she has some new language of H.266 with lots of H.202 embedded in that.
Good afternoon, Jen Parby from the Office of Legislative Counsel. So I have language that is posted on your website. This is based on your conversation from right before you left for the town meeting week break. Should see draft 1.1.
H.266.
66, and they have to refresh. I just sent it to Kristen maybe 5 minutes ago.
Which graph you looking at?
1.1.
Gotcha.
So most of what this is striking out language that was in the bill in 266 as introduced, because you had talked about taking out the insurer PBM part. So section 1 is the new subchapter on 340B drug pricing. I've struck the definition of health insurer because it is no longer used. If we strike out all of this language about reimbursement of 340B entities. So I'm just proposing striking this out of the bill. And then renumbering the remaining sections of that subchapter. In the private right of action, taking out, again, the references to the health insurer, manufacturer, or third-party payer, and just saying anybody injured by a manufacturer's or its agent's violation. It did highlight in green here, there had been a question about what a package of 340B drugs is. I still don't have a good explanation for that. So if anybody has thoughts on a better terminology, that would be great. And then I've taken out the reference to the prohibited act involving the health insurer or PBM. And then taken out section 2 of H.266 as introduced, which was itself striking out some language in the PBM statutes that was being kind of replicated and expanded in 266. So this isn't proposing to take it out of statute, it's just proposing to take it out of the. And then what would become section 2 was section 3 of H.202. This is what I think you have most recently been talking about, which is reporting on participation in the 340B drug pricing program. This does have the reporting happening annually, and it has them submitted, the hospitals submitting to the Green Mountain Care Board a report that gets posted on the Green Mountain Care Board's website, but it does not, as you discussed, does not have the board creating its own report of the reports. And then finally, the effective date, the act would take effect on passage, and this was the language from H.202 for the effective date. The first report under section 2 would be due by July 1st of 2026. That's it.
Devin has,
Devin Green from Badge. I have a more information about the page, which sorry about that.
No, that's okay. I had forgotten.
It's the usual unit sold to the pharmacy through the wholesaler.
Say that again?
A usual unit sold to a pharmacy through the wholesaler from the manufacturer.
do we have to have a definition?
I don't know. Can I consult the side of the room for a moment? Package
Package bill in the last we did something.
Okay. So it sounds like package is a
Okay.
known term in the pharmacy industry.
So we don't need to have a definition of package.
I don't.
Wooded package.
Okay. Either, if we were going to have a definition, I would look for a federal definition that we could piggyback on, not create our own definition. Thank you.
Any other comments? Go ahead, Woody.
I realize we're collecting this data, we're going to give it to the Green Mountain Care Board. And they're going to use it to help, I guess, regulate the system, or at least
Understand it better.
perhaps. Is there a reason why we're leaving out the healthcare reform official in DMH?
Oh, in AHS and the Agency of Human Services?
Yeah,
I don't think, I mean, you have recently in last year's legislation created a kind of prescription drug oversight or prescription drug cost oversight role in the Green Mountain Care Board. I don't know that there is something similar in the Agency of Human Services.
There is the healthcare reform person that's supposed to be making changes to our system. Shouldn't that person, be part of this as well? I'm just throwing it up.
Well, the language of the bill, at least the reporting part, just has the information being provided to the board and the board posts it on their website. So I'm not sure what role you would see the Director of Healthcare Reform having.
Well, if he or she is reforming our system, would think that they would want to be part of this and.
Or to the committee.
But it's just a thought.
I think they can access the data if it's posted publicly. Right? It's just data and report. Or if you want to reach out to them and ask them if they have thought. Right? Because Jen, you'll be back in on Wednesday or Thursday.
Again, all week.
The end of Wednesday,
Hopefully.
we'll be talking about this after 4 and doing a review.
Yes, I think we are doing more work on this tomorrow afternoon.
I would just like to see our healthcare reform official playing a greater role in, if that person is creating our new system or reforming it, then they should be interacting with the Green Mountain Care Board. Just a thought.
Agree. I like being inclusive too. So you want to reach out to them?
Brendan is supposed to be here any minute.
Well, we can ask them that.
Yeah, he's on the agenda.
Okay.
So there's two things that we've talked about that we've discussed in great length. One is the time period that we should do this, collect this information. And now we're talking about healthcare, their healthcare reform person. How does go ahead.
I just add, so did we agree that we're going to collect all this information? So is there, or just that we're going to collect it and that we're going to put a sunset on it?
Well, that's
That's a question, right?
the question.
Okay, so whether or not we're collecting, like what data we're collecting and then for how long?
For how long?
Okay, great.
And which system?
A what?
Which system, whether it's Maine or Minnesota or,
Well, that's not a system, that's
well,
just,
which
right,
legislation?
Which method?
which method? 202 or, yes, so what data and then
How long?
how long? Sorry.
Yeah, something you said earlier, Lori, that you didn't say now that I want to ask about is you said something about how we were going to use it or like what the purpose was. Like, is that something we're going to put in language in the bill, like our intent, like, or would it be beneficial to say like the intent is to collect this data for this reason? Like, I don't know.
I could go either way on that. I think just that we as a group need to understand what we're going to do with the data when it comes back, whether, and if it's the Green Mountain Care Board or whoever we're getting, so maybe it's not us doing anything with the data, but whoever gets the data, like, is it really data that's usable, that's gonna help us know that this is helping Vermonters, policy that we're putting in place is helping Vermonters, and how do we, kind of like the accountability, right? Like, how are we gonna know all that? And if a piece of data is hard to get and it's not gonna help us, is there a different type of data that we can get that would help us? So that's all. I have no opinions. I just want to make sure that whatever data we're asking for, especially if it's a burden, is usable.
And so I think what I would say is I want to make sure that that sentiment survives into future bodies. And I don't know if that, if it's, I just don't know if there needs to be intent or purpose or something attached to the bill. So then, I don't know, but I just want to make sure that doesn't get lost
Yeah.
in the shuffle, what Lori's saying, I guess.
Yeah.
Because we all might get voted out after this year.
The sponsor of the bill. How do you feel about that? Isn't there something in the beginning of the bill? I don't have the bill in front of me.
There's more to H202 than just section 3, so what it says in the introduction addresses other things that we're not talking about today. I personally still lean toward I hear what the hospitals are saying, and I lean toward the Minnesota methodology because we have more detailed information. So I'd like the committee to have more discussion about that. I know we're going to be talking about it tomorrow, and possibly voting on the bill. I think that's one of the points, definitely, like Lori said, that's one of the points we have to decide is what methodology we're going to use for the data collection. And then to decide, I would like to see a report come out of it. We can't bind future legislatures into doing something. But I also don't want to add to the Green Mountain Care Board a thing that they said that they don't have the capacity to do right now. And even though we do have legislation pending that would give them more resources, that legislation hasn't passed yet. The governor hasn't signed it.
Okay.
So this is sort of a merging of Alyssa's 266 and your 202, right?
Yes.
So correct me if I'm wrong, but the next steps will be for the two of you to discuss what we've discussed in here and Jen to make those changes. And then tomorrow after floor, we will come together, review, and possible vote.
Yeah, and to make things more interesting, I'm not going to be here tomorrow.
Okay. We'll just do what we want then.
Fine.
I have a question, but also a comment first. Did you just say something about not binding future bodies to things?
Yeah.
Yeah, that is what we say here, but I just have to say that I feel super bound to things by past bodies and that we are dealing with 50 years of policy that binds us now. So even though we're not supposed to do it, everything we do does bind future generations, whether we like it or not. But that point aside, they can change it, but like, and we're trying, right? But I'm just saying, like, everything we do does, unfortunately. But that being said, the question I had was, I may have missed it in the testimony, but has anyone put side by side the methodologies of these different proposed models? Like, is there a slide anywhere where it's like, here's what Minnesota does, here's what Maine does, you know, where we can look at it like that? Because, and if not, I'll just reread everything, but it would be helpful if there was something like that out there to see.
I'm not saying no.
I thought maybe you were saying like, no, we don't have one.
I was just shaking my head at someone else.
Yeah, I don't know.
I can try to look and see if I can find it.
And I don't want to make extra work for anyone. It just, if it was out there, it would help me to look at it. And if it's not, and if there's something out there that someone could just send to us that we can review, it would be helpful. Or if someone wants to make their case about why one thing's better than the other, they could always lay it out side by side for us and show us.
Okay.
Thanks.
Any further discussion? Any further questions from anybody? Okay, Daisy, I'm gonna ask you to just the three things that we're gonna be looking at,
Okay.
just summarize them.
We're gonna touch base with Brendan when he comes in about letting the healthcare reform person know that we're working on this. And the other thing is Alyssa and Mari are going to touch base regarding the Maine versus Minnesota language. And the third thing is the sunset suggestion and how long. I'm hearing the Office of the Healthcare Advocate suggested 5 years. The hospital suggested 3.
Okay, three.
We'll take a recommendation on that and discuss it tomorrow, those 3
Okay.
things.
And committee member recommended 2.
This committee. remember-
Decades.
Okay, so I'll say 4.
Decades. We'll discuss it tomorrow.
Okay. So all of this will be ready for tomorrow afternoon when we deal with this again.
I get.
We're getting closer to something.
Okay.
One more comment, it was also recommended, there was a strong recommendation from a pharmacy expert that the data come from the wholesaler, and I think we heard that in Devon's, right, in your report, so.
Can you explain that again? So,
So if I can get this right, the drug wholesalers get drugs from the manufacturers and then that's the next step in the drug distribution system. Do I have that correct? Ish.
Then they go to the pharmacy.
So there would be a lot of information in that one place, the wholesaler, about the 340B program medications.
Well,
That's-
hold on. If we have someone else in the room that understands,
I'm just looking to you for permission to
go ahead. I was gonna say, yeah, have him come up.
Thanks, Jen.
Thank you, Jen.
Sure, thank you, committee. Jeff Hochberg, Rutland Pharmacy. So yes, the drug wholesalers are the distributors of all medications. So how 340B actually works is the product gets shipped to me. I do my business as normal. A third party captures the data on that business. They recognize what is 340B qualifying or not. The wholesaler then charges the entity for the product and credits me for the product. No product actually changes hands. This is all virtual. The wholesaler knows exactly what is 340B and what is not 340B in the utilization in the state of Vermont and in the entire country. Go to them. It's very simple. They have it all in their fingertips. It would not be a heavy lift. It would eliminate the burden from the hospitals and you get access to data.
So a question, they do have most of the information or all the information.
Everything.
But when you're giving Green Mountain Care Board or some other entity, can they demand to get reports from everyone?
Green Mountain Care Board has authority in my
Okay.
understanding to get
And that's my point.
information
You know,
from
the
anybody.
burden
anytime.
sometimes we don't understand might be. You know, if the wholesalers right now, they got all the information, pretty simple. But will it stay simple? When you start giving authority to others to demand,
I don't know if I understand your question.
okay, so in other words, Green Mountain Care Boards gets theirs from they get their information from the drug wholesalers, okay?
Uh-huh.
And can they go to you as a pharmacy, say, now listen, I want a full report on everything?
Any government entity, agency, individual can ask a pharmacy any question, whether confidential or proprietary, as long as confidential is
And- and-
maintained,
and I
and I
guess
can disclose that
my
information. to
question would-
anybody.
Could it be a big burden on you?
I've been given information
Okay.
for a long time.
Okay.
So no,
I don't understand
Free.
pharmacy. Yeah. Yeah.
And if you don't understand, exactly, I think this body needs to understand pharmacy. And if the point is to understand
Yep.
prescription drugs more, you need to get data. So consider the wholesalers as a source. It would eliminate the burden from the hospitals and it will provide you whatever level of data you need.
Okay, good. Thank you. Any further discussion that we need on this? Well, I just want to make sure. I'm going like this right around the room.
I'm still
Okay.
processing what I just heard. I don't have any questions. That's why I'm just like thinking about it.
Yeah, so am I.
Yeah, so.
You know,
I need to digest
maybe-
all of
Maybe,
this,
maybe
like-
the line of how we get the information may change, may not.
Yeah.
Okay, so we are done with this. Right? You've got all the information you need.
I have no direction. I talked about all the things you need to talk about, but I don't have any.
So we haven't told you what to do.
I guess we should do that with the committee then.
Alyssa and I will talk and then you'll all talk tomorrow.
Well, we know what the three things are, that we talked about them already.
Yeah, I just
And
wanna-
Jen is gonna incorporate those.
We know.
You haven't given me direction.
Yeah, Mari and Alyssa need to talk.
And
And
then
then we all need to talk.
you all need to
before
talk.
we can.
Okay,
So am I hearing that Mari and Alyssa are gonna talk and then send something for us to review tomorrow that will then give us direction? Like we will have they're gonna come to us with a
Yeah,
proposal,
that's
and we're gonna look
right,
at it, all
but
right?
Jen is coming in tomorrow too.
I will be coming in, but unless you give me direction, I
Direction,
won't have a new
you
direction.
won't have
I mean, all
anything
I have
else
is
to
just-
do.
I cleaned up all the stuff you were taking out.
And you're ready for anything.
I'm ready for anything,
Yeah.
exactly.
We can
Well,
create
look,
universal
let's-
healthcare tomorrow.
Let's at least get the three things we talked about.
Yeah.
Is there any objection to the three things that we talked about?
we're not quite, I think it'll be easier for people to grasp. Once I'm sending some information by email about Maine and Minnesota. And then when Alyssa and I can come up with some suggested language, you all get to decide whether you want to expand it or change it or do something completely different, but at least we'll have a place to start from
That makes sense.
and it'll include the three things.
Okay, yeah, all right, then. we'll-
That makes sense.
Okay. Alyssa knows she's doing this, right?
She'll.
But she asked me to take notes on what needed to be done. Okay, all right. And Alyssa is gonna then provide Jen with the information that she would like to have.
Probably, well,
Tell her we got it. We got it.
Okay, I just wanna make sure.
I have one request from Mari.
yeah,
Would you consider, not attached to it, but would you consider like a statement of purpose or intent in your recommendations for us to look at, just to kind of ground us?
Sure.
All right, thank you.
yeah, I think it's a good idea.
All right.
You want to take a stab at a suggestion?
I can send you a sentence. I'll send you a sentence.
That'd be good. And maybe on a plane.
Yeah, I'll send you a sentence and then you and Alyssa can look at it. Thank you.
Thank
Okay.
you.
Enough?
On a different topic, it's this topic, but I was reading.
Point of order. Just kidding. You said it was a different topic.
No, well, it is sort of, it's from DFR and Emily Brown sent us a written testimony. And I was reading that and wanting to understand, needing some help understanding it, I think. And how it fits in with our conversation. Because she's saying the department cannot support the provisions of 266 that would keep health plans and PPMs from tracking or otherwise verifying the integrity of 340B programs. And
This was, you just took all that out of the bill.
thank you. That's what I needed help with.
Okay.
Good.
Good job checking though.
So we are done with this. It's up to you, Mari, and Alyssa now.
Yeah, wait.
Easy says we've got it all covered, so we're done with this one. All right, now I think what I would like to do is take a little break, a very short break, 5 minutes, and then come back so that we can reorganize what we're going to do here. So if you want to take a break, go ahead.
We all.
Oh, we got to come off.